Hello and welcome to our new topic, one of the most important ones. Today's topic is about the drug treatment of the most common cause of mortality globally, responsible for so many complications and constitutes one of the largest contributor to the non-communicable disease burden. Yes, that is ischemic heart disease, including heart attack. Since many drugs used to treat ischemic heart disease are also used in other disorders or have already been discussed separately, like diuretics or adrenergic antagonists, we will focus here on those drugs which are not discussed anywhere else, to avoid duplication of the content. So, let's start. By the end of this lecture, you should be able to describe the drug targets in ischemic heart disease, classify them according to mechanism and site of action, explain their pharmacokinetics and therapeutic uses, and understand rational drug combinations to treat acute coronary syndromes. Let's begin by defining key terms. Angina pectoris refers to pain, typically from central chest, arising from myocardial ischemia, usually after exertion. Unstable angina occurs even at rest, and any new onset angina is considered unstable and managed accordingly. A myocardial infarction, MI, or heart attack involves necrosis of the heart muscle due to prolonged ischemia. Together, both unstable angina and MI constitute the acute coronary syndromes. The pain of ischemic heart disease results from insufficient oxygen supply as compared to its demand, often due to narrowed coronary arteries. Coronary occlusion from a combination of an slow-progressing atherosclerotic plaque or its sudden rupture, and resultant thrombus formation, is the usual cause. Other contributing factors include aortic stenosis or vasospasm. Pharmacological therapy therefore targets both oxygen supply and myocardial demand, and depends on the underlying pathology. Treatment aims include reducing ischemia and cardiac workload through nitrates, beta blockers, calcium channel blockers, and ACE inhibitors. Resolving vascular occlusion using thrombolytics, anticoagulants, and antiplatelets. Controlling pain and anxiety with opioids. And preventing complications through long-term use of ACE inhibitors, beta blockers, and statins. This slide shows the typical pathogenesis of ischemic necrosis and drugs used to treat it. Coronary atherosclerosis, which is a chronic inflammatory process, may rupture inside the arterial lumen, starting thrombosis and vascular occlusion. This leads to ischemic pain and coagulative necrosis of the myocardial area supplied by that artery. Necrosis is followed by local inflammation and failure to achieve complete repolarization of cardiac tissue, thus predisposing to arrhythmia and pump failure. On the other hand, a necrotic myocardium is unable to function, leading to pump failure. Thus, we have several steps where we can intervene in this pathogenesis and also provide symptomatic relief, as shown in this diagram. Note how various drug classes intervene. Statins stabilize plaques, antiplatelets and anticoagulants prevent thrombosis, nitrates and oxygen relieve ischemia, while beta blockers and ROS antagonists protect the heart from remodeling. Nitrates, listed as fourth, is our main topic in this lecture. Other drugs are discussed in separate lectures and can be viewed on the channel. Nitrovasodilators or simply, nitrates are classified into three groups as shown in this table. Out of these, the organic nitrates are the main drugs used in acute coronary syndromes. They work by generating nitric oxide in the vessels, which activates guanylyl cyclase to increase cGMP within vascular smooth muscle, causing relaxation. The net result is venodilation with or without arterial dilation, which reduces preload, afterload and myocardial oxygen demand, thus reversing ischemia and relieving chest pain. Additionally, nitrates inhibit platelet aggregation and relax other smooth muscles such as bronchi and git. Nitrovasodilators are prodrugs that release nitric oxide via enzymatic bioactivation by aldehyde dehydrogenases. Short-acting nitrates like sublingual nitroglycerin provide rapid relief, while long-acting preparations such as isosorbide dinitrate or mononitrate are used prophylactically. Amyl nitrite inhalation is now obsolete. Vascular endothelium naturally produces nitric oxide, and the amino acid arginine is the natural donor of NO. The organic nitrates generate NO metabolically as explained above and activates guanylyl cyclase enzyme to produce cyclic GMP, which eventually dephosphorylates myosin light chains. CGK1 dependent, causing vascular smooth muscle relaxation. Key clinical effects include reduced cardiac workload and relief of anginal pain due to vasodilation. Adverse effects such as hypotension, reflex tachycardia, and pulsating headache are common. Continuous use can lead to tolerance, particularly with transdermal GTN, so nitrate-free intervals are necessary. Nitroglycerin patches should be removed before defibrillation due to fire risk. In the unlikely event of inorganic nitrite generation, the ferrous iron in hemoglobin may get oxidized to ferric form, thus forming methemoglobin. This hemoglobin is unable to carry oxygen and may become fatal. Methylene blue is the antidote. Other drugs beneficial in ischemic heart disease include calcium channel blockers such as nifedipine, diltiazem, and verapamil. Beta blockers like propranolol and atenolol. And ACE inhibitors or ARBs, including enalapril, lisinopril, and losartan. Each group reduces cardiac oxygen demand through different mechanisms. Therapy must be individualized for each patient's comorbidities. For vasospastic angina, calcium channel blockers and ACE inhibitors are especially effective. To decrease contractility and heart rate, beta blockers and non-dihydropyridine calcium channel blockers are used. For preload and afterload reduction, calcium channel blockers combined with ACE inhibitors or beta blockers work best. Some vasodilators such as the arterial dilator dipyridamole paradoxically worsen ischemia via the coronary steal phenomenon. It inhibits adenosine reuptake in vascular smooth muscle and also increases half-life of its second messenger cyclic AMP. We know adenosine is a vasodilator in hypoxic or ischemic areas, and it also inhibits platelet activation and aggregation. Now, this coronary steal phenomenon involves differential arterial dilation in the healthy areas as compared to ischemic area which are already at near maximum dilation. Also, it does not cause dilation of collateral vessels. Thus, dipyridamole diverts the blood towards healthy tissue, further depriving the ischemic zone. This is in contrast to nitrates and other vasodilators used in ischemic attack. Hence, dipyridamole can be used for diagnostic purposes in stress testing rather than for routine angina management. Or, used as an antiplatelet drug. The overall management of acute coronary syndrome involves relieving ischemia and preventing further clot formation. Nitrates, beta blockers, ACE inhibitors, and statins form the pharmacological core. Antiplatelet therapy and anticoagulants address the thrombotic component. Ongoing lifestyle and risk factor control remain essential for long-term success. Here various drugs and combinations are compared. Take a closer look. The reflex tachycardia with nitrates and other direct dilators is due to intact sympathetic control. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!